We'll start the recording now, and we'll start admitting.
Cool.
Good morning, everybody. Welcome. I'm just letting you all know as you're coming on that we do have a couple security features set up. All of your microphones and your cameras are turned off just for security. When you do have questions, please post them to the chat feature on the bottom right hand of your Zoom screen. And so we'll take questions at the end. And I'll wait for everybody to get on. We still got quite a few people coming in.
Awesome.
All right, it's 10:01, so we'll go ahead and get started. I'd like to introduce y'all to Crystal Olivera. She's our Chief Development Officer at the LSU Health Foundation.
Hello, everyone. Thank you for joining us. This is our 6th webinar in our series about coronavirus, and today we are joining you from our homes with Dr. Fidel and Dr. Hagansee. Dr. Fidel is a professor and chair of the Department of Oral and Craniofacial Biology and Associate Dean for Research at our LSU School of Dentistry. And Dr. Hagansee is Professor of Medicine, Section of Infectious Disease, and Vice Chair of Research. We will be taking questions at the end, so please use the chat feature to post your questions. And Dr. Fidel and Hagansee, thank you. And we're so excited to have you on this webinar, and we will let you take it from here.
All right, thanks very much, Crystal.
Thank you for having us.
Move up and screen share in a second. But I just wanted to reiterate the fact that I'm at the dental school, but I am a microbiologist and immunologist by training. And Dr. Hagansee here and I have worked on research projects for the past 25 years, a lot of clinical research, and continuing now, and even in the COVID arena, relative to some research projects that we're putting together. So I'm going to go up and do my the screen share here, and hopefully that comes up.
There we go. Awesome.
All right. So, our sort of our title is diagnosis, treatment, prevention, and we want to come up with tell you about a few new concepts that are happening now, and try to give you more of the most up-to-date information. I'll be covering some things, and I'm going to have Mike jump in and give his own experiences from being in the trenches of treating these patients and seeing them and being real close to the action. So in general, this COVID-19, the definition is coronavirus December 2019. This is a SARS, we call it SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome, coronavirus number 2. And it's number 2 because it's the second SARS coronavirus pandemic. The first one was in Asia in 2003, if people recall that. And it was fairly contained in that area. Now this one has spread much more globally. This is an RNA virus, and the exposure that we see through this, you see the picture there on the right that everybody shows anymore. The exposure of this is through aerosol. Aerosol is definitely the number one cause of exposure and spreading, and then touching as well. And the symptoms that normally you see with this is cough, headache, fever, fatigue. Some people have seen loss of smell and taste. Some people have claimed some pink eye symptoms. And then a big one is shortness of breath. And that's what we're sort of going to focus on in what we're showing you today. there's no previous immunity against SARS-CoV-2, so there's no vaccine, and really nobody has any immunity against it. So it's a brand new virus that we sort of have to get through to be able to generate the immunity. Just briefly, the diagnosis is by testing. This is by PCR, polymerase chain reaction. Just identifies a match for COVID-19 RNA. So it's just identifies it as the COVID-2. The criteria that you normally see for the testing, because the tests are limited, are fever and or shortness of breath, together with a cough. The other way to diagnose and test this is from seropositive, sort of the antibodies made to COVID-19 will be specific for it. But these, as I said, no one had these to begin with, so this is all going to be induced post-infection and most likely post-symptoms. So you won't see these antibodies pop up and get induced until well past the main symptoms in the infection. But it is evidence that you've been exposed to it and now presumed immune, but that is presumed. We don't know that that's actually the case yet. So treatment is an interesting area right now because a lot of things are being tried, and Mike will tell you that that some of the results per se at this point, but you've heard of hydroxychloroquine. That seems to be one of the main agents that they're testing, plus or minus azithromycin. This is not proven at all. There's reports that from small sample sizes that the hydroxychloroquine might be antiviral, but it does appear more likely to act on hypoxia, which is low oxygen and shortness of breath. The azithromycin helps as an antibiotic. It's really going to help against bacterial pneumonia. It's also potentially anti-inflammatory, so it can help. There's current trials are ongoing, I think we're even initiating trials here in New Orleans. The results, early results, I would say aren't that encouraging, only from the standpoint of there's one big trial in Brazil that was recently started that is going to enroll 400 patients. They used 2 doses of the hydroxychloroquine, a fairly high dose and then a more normal dose. And one of the side effects of hydroxychloroquine is heart arrhythmia. And it turns out that a lot of the patients that were given the higher doses were getting these heart arrhythmias. They stopped the trial after 81 subjects, and only one of those 81 showed any positive results. Mike, what do you see in the clinics with this?
Yeah, one of the main problems is that we're seeing a lot of observational data, meaning they put patients on hydroxychloroquine, and some get better, some don't, and so there's not any randomized clinical trials yet. I'd say there is one that was published out of China. It was only 31 patients getting hydroxychloroquine and 31 controls, and there was some modest improvement in the ones that had hydroxychloroquine. And if you look closely at these studies, the ones that got hydroxychloroquine were actually less severely ill. So it's a little hard to make any sense of it. And you need hundreds of people to be able to see a true outcome. We are starting a randomized clinical trial we'll have at University Medical Center here in New Orleans. I think now we've enrolled about 10 patients. The goal is actually 600 to get 200 on placebo, 200 on hydroxychloroquine, and 200 on the combination of hydroxychloroquine and azithromycin. Go ahead, Paul.
All right, thank you. And so another one is the sort of antiviral drugs specifically. Remdesivir is a previous antiviral that worked in the SARS epidemic. There are current trials initiated ongoing using that. I hear fairly positive results of that, but there's nothing, I haven't seen anything concrete. And then another one is this favipiravir. It's an antiviral. The FDA is just approved for the United States. There are current trials that are being done in Japan. What do you know about those, Mike?
Yeah, the same thing. There was a publication in New England Journal of Medicine last week on remdesivir, when they just used it what we call for compassionate plea. So they used it. There's again no control arm, and they showed about 60% of the patients got better, but we don't know if that's efficacious or not until we do the randomized trial, which are ongoing. I do know Tulane Hospital is part of one of the clinical trials for remdesivir here locally. And then some other hospitals have the ability to acquire this for expanded access. We'll have to wait and see. I have utilized this a few times. It's not been a miracle drug to me. So that's why we need to do these clinical trials so we can see who may benefit from these agents. Hi, Paul.
All right, so the other one is a big one right now, convalescing serum. This is a passive immunization. This is antibodies that are specific to COVID. This is coming from taking plasma from somebody who's just recovered and then giving it to somebody else with severe symptoms. You may have seen Sean Payton just donated his plasma yesterday in effort to test a lot of these. This has been going on for about a month now in several trials around the country. It actually, likely to be safe. The issue with convalescing serum therapy is it is antiviral. It does go against the COVID-19 virus, but it's going to only be effective against the virus if it's free and out of cells, sort of in the blood or in the periphery in the blood. Once it's in cells, in terms of how viruses function, they're parasitic. They get into cells and mess up all the machinery, and then make more of themselves, replicate, and then jump back out. It's only going to be effective against the ones that are outside tissues and cells. That's why, in general, vaccines work so well, because the vaccine produces the antibodies that are probably very similar to what we're seeing here with convalescing serum. But those antibodies are ready and waiting when a virus enters the body and can get rid of it or kill it off before it really gets into the cells too much. So in this case, it's sort of the backward way of getting to it, but those viruses do come out of those cells replicating, and the convalescing serum does have a potential to kill those viruses, at least that are outside the cells. No solid data yet. Mike, do you have any solid stuff on this?
Yeah, just to explain to people, this is like getting a blood transfusion. Your donor just has to be someone who has recovered from COVID. And hopefully, as we get serological testing up and running, that can test to see if that donor has antibodies, and maybe even a high titer, high quantity of antibodies to be potentially more effective. There again, the observational data looks promising, but again, there's no control arm for this. The convalescent serum, interestingly, for different infections has had different efficacies. As you can imagine, for SARS-CoV-1, actually it seemed to work very well, but you had to get the transfusion within 14 days of your initial symptomatology. So that's one thing that was a randomized clinical trial. For example, it's talked about using it for Ebola. However, when you went and looked at that data, it did not work for Ebola, no matter when you gave it. So I think it's safe. I think it's worth trying. It's widespread in terms across the country. I know East Jefferson Hospital is up and running here. University Medical Center is getting their convalescent serum program moving as well. Again, we're going to need to do the randomized clinical trial to see if it's efficacious, and then at what point in time is it. It may be like the SARS-CoV-1. We might need to get this early in those first 2 weeks. When symptoms onset.
Yeah, and the key here is the person who's recovering has to have the antibodies, which we don't really have any true confirmation, although it's presumed. The one good thing about this is there's no blood cells, so you don't have to be a match per se. You just basically have to have recovered, and those antibodies are in the serum, and no issues of having to match like you do with blood cells and transplants and stuff.
Let me clarify that, Paul. It is like a blood transfusion, so it's an ABO match. but it's not like a bone marrow along those lines.
Right. Okay.
So it's like you're getting donating a pint of blood, and then the recipient has to match it that way. But we don't know if that donor has good antibodies against the virus. We're presuming, since they recovered, that they do, and that's probably a good assumption.
Right. Yeah, the factors will still be in there.
Right.
The last one is anti-inflammatory mediators. I haven't heard much of this except for really at the beginning of the pandemic, where there was a lot of interleukin 6, which is a pro-inflammatory cytokine, immune modulator mediator, and potentially people were speaking about trying to use anti-IL-6 antibodies to try to curb the inflammation that's associated. But I haven't heard anything since.
Yeah, there are a couple different mediators they're looking at targeting. Interleukin 6 is the main one. There's a couple monoclonal antibodies that are commercially available, have been tried. Also, GM-CSF is another inflammatory. And the whole idea here is that this cytokine storm, that you start this inflammatory process and then you can't reverse it, and that leads to a bad outcome. And the idea is to try to calm that down. And it's challenging because it's not clear necessarily which patients are going that direction or not. And so, again, what time to utilize these agents is not clear. And these are somewhat pricey monoclonal antibodies as well. Again, a few times I've seen it used. I haven't seen it being used successfully yet. But like all the other therapies, we're going to need to, as things evolve, try to get some randomized clinical trials to see what works and what works when.
Yeah, and we'll be discussing the strong inflammation here in a second, but this is really the shortness of breath and all the issues that come in with the lung inflammation that we're speaking of. All right, so let's move on to prevention. We'll do this one kind of quick. Everybody's trying to do social distancing, 6 feet, washing hands for 20 seconds. Soap is best. Hand sanitizers obviously good as well, and a lot of distilleries now are making hand sanitizers, so that's a good use of the distilleries at this point. Face masks are becoming more and more the norm here. Originally, it was not thought that the face mask may be doing as much, and it may be hurting because you'd be messing with it, touching your face. But it turns out that this is mostly respiratory exposure, and so anybody that is wearing a mask would prevent a little bit from coming their way and certainly from getting out from themselves. I did see this morning on the Today Show that a hard cough can spread about 9 feet. So the 6 feet may not be quite enough if somebody's not covering their mouth, but masks and covering your mouth will at least shorten that distance and push it more upward or downward and not out so much. So that's a good thing. But the face mask really should be worn if anybody's out in public, into any grocery store and so forth, and the tenants of the stores themselves should be wearing them conversely. So in terms of isolation and quarantine, we all know that people have quarantined and isolated if they've known the exposure. The rule of thumb is if you're within 3 feet of somebody for at least 15 minutes that has tested positive at some point, then you need to go away for 14 days and from the time of that interaction. Or the time of interaction of the, time of interaction, they as long as they have been diagnosed positive. So the issue is, can there be medical measures that are preventive? And yes, there are. The vaccine is what we really want. This has to go through many phases and determine the right antigens to get the vaccine that's functional. It has to go through animal studies for functionality. Then it has to go through phase 1 safety trials, and phase 2 and phase 3. So we're 12 to 18 months away from that at the least. So we have to wait for that to happen. Hydroxychloroquine is being proposed and tested prophylactically now, which is a very interesting thing. Mike, I think you know of some of these that are starting prophylactically?
Yeah, there's a couple of big national trials that are going out and using this, usually at a little bit lower dose than what we're using in the hospital. as Dr. Fidel alluded to, there is a heart arrhythmia issue, which is actually very, very rare. And it's something that we obviously monitor in the hospital in the COVID positive patients, and it may actually be more of an issue for them. But that's one of the concerns, and the structure of these trials is to give this for now maybe up to 3 months. And we obviously want to do something that's safe. And so that's kind of the nature of these trials. But they are designed as, again, randomized clinical trials where we're seeing some people get placebo, some people will get hydroxychloroquine, and then we'll be able to know if it actually it does work as a prophylactic medication.
And normally, I think this would be more earmarked for people with high-risk exposures.
Yeah. So they're targeting healthcare workers a lot in a lot of these trials. Now, one thing I would say about our healthcare workers in the New Orleans area, they're probably already all been exposed. So a lot of this might be used in less infected areas right now to try to prevent any spread there.
Right. Another one that's come up just recently has been a Povidone-Iodine antiseptic solution. It turns out that it seems to be very effective against coronaviruses in general, more so than even other types of viruses and bacteria. A betadine solution is a 10% Povidone-Iodine, and it's suggested that potentially a 0.5% solution, which is a 20-fold dilution of that, could actually be used as a nasal spray or a mouth rinse to, if anybody felt they were exposed or anything like that, they could potentially use this just as much as they're using hand sanitizer. So that is very new. I've just seen that come across in the past week. But are there others? And I think this is what I want to focus on a little bit. Look at the big sequelae of COVID-19. The primary factors that are really killing patients is the respiratory distress syndrome of ARDS, acute respiratory distress syndrome. It's very much a lung inflammation. Fluid builds up. You're sort of drowned in your lungs, per se. You have difficulty breathing. It's sort of called spongy lung. With all the fluid buildup, you lack oxygen, not enough oxygen passing through. Hemoglobin is low, and then this puts everybody that has these symptoms in the ICU and put on vents. And this is a sepsis. This is a tremendous inflammatory response by the body to rid the infection, and it is focused somewhat, in the lung area because of the respiratory virus itself, and that's where it sort of sits. So it's damaging to the tissues and organs, and ultimately you get this severe inflammation that's not controlled. You get organ failure, and these individuals are passing away. So really, besides preventing the spread of COVID-19, another best preventive measure may be against the lung inflammation and sepsis. We spent a few minutes on this, looking at some clues to how this could occur. We look at children versus adults in general over the past pandemics of flu and coronavirus. Very interesting epidemiology data. Turns out that the coronaviruses, all those pandemics, children were much less susceptible than adults, and the mortality rates were much less in children than adults. In both the SARS from 2003, MERS from 2012, and now COVID-19. In contrast, the flu epidemics that have occurred, especially even 100 years ago, with the Spanish flu and everything, that the children have very high mortality rates. Died viral and bacterial pneumonia, a lot of comorbidities. But children had really high mortality rates with the flu. So what's really a difference? Well, why are children more protected against the coronavirus? It turns out that one thing that you can think about is that children are more recently vaccinated against childhood diseases at that younger age. These are live attenuated vaccines, MMR, which is mumps, measles, mumps, and rubella, chickenpox, smallpox, rotavirus. These are live viruses that can't cause infection, so they're called attenuated, but will induce the immunity if someone's ever exposed. So there's no immunity to COVID-19 per se, but it's just interesting that is one difference in children versus adults. And you ask the question then, could live attenuated vaccines be helping these children against the coronavirus infections. And it's, again, not related specifically to COVID vaccine, but I'm going to say yes from the standpoint that it could be related to the sepsis factor. Let's take that a step further. Look at sepsis research in general. The live attenuated vaccines, their primary role, as I said, was to induce immunity, to target the pathogen, to protect against it if you ever get exposed. So that's what we call adaptive immunity. That is what vaccines are made for. They're specifically to induce the immunity so that anybody's exposed to that particular target pathogen, that they can get rid of it before the symptoms start and before they get sick. Well, there's an added advantage to live attenuated vaccines, and that is that they can also induce cells that will inhibit sepsis that are associated with infections much more broadly. So it's not just COVID, it's sort of more anything, or not COVID, or not just infections that would be COVID related or otherwise. This is very broad. And so this is called trained innate immunity. And this is a new concept that's occurred over the past 10 years, but a lot of animal studies worked on this now. A lot of studies that are beginning in humans as well to understand this sort of trained immunity that's not your normal adaptive immunity, but it's more from the innate side with cells that are not normally memory cells and cells that would be produced to target the pathogens. So you look at children versus adults in general, and you ask, could a childhood live attenuated vaccine booster help protect adults against the COVID-19 lung inflammation and sepsis? And so, we're speaking about this more of a new concept here as a preventive measure against the sepsis specifically. And so we're proposing the administration of the MMR vaccine, the measles, mumps, and rubella, really to healthcare workers and first responders, really any adult with risk of exposure to COVID. But it's not to be antiviral against COVID-19 in any manner, but rather really to induce these trained innate cells that can inhibit the sepsis if infected with the virus. And it turns out there's no contraindications for MMR vaccine for adults. The CDC actually recommends an adult booster. The only exceptions are if people are immune compromised in any way, if women who are pregnant, and people who have allergies to vaccines. It sort of ends up to be a low risk, high reward preventive measure. It's sort of a no harm, no foul idea, because if we are correct, the vaccine could protect against that terrible lung inflammation and sequelae associated with COVID. If we're wrong, well, then we as adults are now have better immunity against measles, mumps, and rubella if we ever came in contact with that as an adult. So it's sort of we call it a high risk, high reward preventive measure. It's not unprecedented. There are actually in the past month or 5 weeks now, several trials have begun around the world, Netherlands, Australia, even one now at Mass General in Boston, with the BCG, which is the attenuated live vaccine against tuberculosis. It's a similar concept in mind, though. It's with the concept of inducing trained innate immunity that might help curb what's happening with COVID-19 while we generate the specific immunity from a vaccine standpoint or individuals themselves. And some of this trained immunity can be enhancing, sort of to help get rid of the virus quicker, and some of it, as in our case, suggesting that the trained innate is actually inducing cells that will inhibit the sepsis and the sequelae associated with it. So we're currently proposing a randomized clinical trial here in New Orleans with healthcare workers and first responders. This is together with Mike, as well as with my wife and colleague who's a professor at Tulane. That was sort of the brainchild of a lot of putting together the pieces of the puzzle to this idea. But we are hoping that we will achieve some funding to get this clinical trial going and to measure those cells in the individuals that have the MMR versus the placebo. All right, and lastly, this is kind of a new concept too, and you may be hearing it on the news a lot now, but it's all about COVID-19 exposure. You know, how can we tell if we've had COVID-19? Was the cold or the sickness or whatever I had in January COVID-19? Everybody wants to know that now. And so the idea of this seropositive testing is going to be important. This is what we spoke of earlier with you make the antibodies to COVID-19 as being infected. There are kits now that are coming out to try to identify whether somebody's been exposed and has made the antibody, whether you were asymptomatic or symptomatic or otherwise, you likely have produced these antibodies. So they're sort of like point of care testing. They're brand new. They are short, quick on-site tests showing if you have the antibodies. It's a finger prick blood sample, almost like a pregnancy test type thing. It's a test where you look for bands that show positivity or not positive. And so if you show a positive test, then you were exposed and now presumably immune, and likely cannot be infected again. But that's not proven. We don't know that antibodies that anybody produces are going to protect them again, because we haven't had anybody reinfected. But if you're negative, then you're still very susceptible. Now, these things are coming online from many, many companies. There's up to 70 right now. And the main issue is validation. You know, whether a true positive or true negative is actually the case. How accurate are these tests? If it's specific for any coronavirus, which is the common cold, in addition to COVID-19, but not specifically for COVID-19, the test is useless. So you're going to be positive. You're going to say, I was exposed, but you're exposed to a common cold from 3 years ago, 5 years ago, 10 years ago, a month ago. Or you won't know. Mike, you want to say anything about these tests and your experiences with them?
Yeah, it's certainly gotten a lot of airtime, and in some situations on some stations they talk about the immune test. And I can't, it's very, very important that we hope that having a high antibodies against COVID will be protective, but we don't know that for sure. We're kind of guessing based on other respiratory viruses in the past, and obviously the huge economic impact. If you're positive and you're recovered, that means you can go back to work and not worry about exposures. It's really important. And if they are protective, let's say, we don't know how long that protection lasts, and will it be lifelong? Will it last 6 months, a year, or not? And that's something that needs to be studied. And we're at LSU trying to get studies going to looking at antibodies. Are they, what the quantity of antibodies that people have, and are they actually neutralizing against either COVID-19 or we call pseudoviruses that have the membrane proteins of COVID-19, but are made in a safe way so that we can test that more easily in the laboratory. I think not only LSU, but I'm sure lots of institutions are looking at these tests. And I think, again, like everything, we'll know more a month, 2, 3 months from now. But I think the next step is to get these tests online, get them quality controlled, and then see how many people are seropositive.
Yeah, the potential for impact is huge. We need to know the epidemiology to know how many people infected were recovered. How many people were asymptomatic and contracted this and never showed any symptom whatsoever, but gained immunity to those that had just slight symptoms, to those that had the severe symptoms. So that's going to be important. Healthcare workers, knowing their status as they work in the trenches, that's going to be very important. And as Mike said, the workforce overall, the ability to return to work, recognizing that we're sort of a little bit less susceptible and can get back to work, would be a huge economic impact all around the country. So these will be very high profile tests once we figure out if they're accurate.
Yeah, the people might say, wow, 70 companies, this is great. This is going to be available for everybody. It's going to be fantastic. But let's say 60 companies have a good test and 10 don't. What happens if you get one of the 10 that have not as good a test? then you have, then you have to try to interpret the results. And as a clinician, we're already dealing with that with some of the tests that directly test the virus. We know the rapid tests are great. We get an answer in 15 minutes, but now we have an idea that maybe 30% of the time, those are false negatives, which means we then repeat them with the longer test that takes longer, and now they're positive on that test. So that's hard for a clinician if you have to deal with a lot of different tests from a lot of different companies if you don't know how good each individual company's tests are. So I'm hoping that, and then obviously the FDA is going to help us with this to try to sort this out, and hopefully we can have some consistency from company to company so we don't have to worry as much about that.
Terrific. All right, with that, I think we'll take questions.
Well, goodness, where to begin with the questions? I have like 12 that I've written. I know that we've got a lot from our participants as well. For me as the fundraiser, you know, I heard you talk about this MMR adult booster vaccine, and you are looking to raise some funding, it sounded like. What kind of funding are you talking about?
Well,
How much money?
Yeah. Well, we have an opportunity for a grant right now that from a foundation that put an RFA out that was for $150,000. We think that for $150,000 we can test 50 subjects, 25 with the MMR and 25 with the placebo, and follow for a year for not only the primary objective of looking at the cells, the trained innate cells, but have enough of a potential incidence of COVID exposure and infection to actually see if there is a positive outcome from any of the inflammatory process.
Is 50 is a good number to be able to produce?
50 is a fairly small number, but I think we could get some strong data for it. I think we need about 10-fold higher than that to really.
So 500.
Yeah, you need almost 500, I think, to truly test the secondary objectives with the health issues.
Obviously, the difficulty here is the time frame. We all want to have a potential cure today, but we also have to do things in a safe and scientific manner to show that something actually is beneficial. The great thing about the MMR is that it's well known to be safe in most people. Not everyone someone who might be immune compromised won't be able to get the MMR, but the vast majority of people can. So it's kind of repurposing a vaccine in a way, so that can move forward very, very quickly. I think the key is to try to look at efficacy in a small sample size, and then be able to get hopefully more funding for a larger study that will actually clearly prove that this is preventative.
Yeah, that's really exciting. Okay, my last question before we take all the others that are waiting is the short and quick test. That sounds really amazing. And for me, I'm thinking, okay, so I can go to my primary care physician and get this test. My daughter can go to her pediatrician and get this test. I mean, is that the ultimate goal with this test? Once we know that the test is reliable and it's, FDA, those regulations are there, so we're not, utilizing faulty tests. Nobody wants.
Right. I think that's why, the first test, it kind of surprised me. The first test that came out were these finger prick point of care, turnaround time 5 minutes, 10 minutes, like Paul said, like a pregnancy test, that kind of turnaround. But I see where they're targeting exactly what you said about that the physician's office could have these and you could very quickly get an answer. And then, well, first of all, I think it's the quality control to make sure that you do have antibodies. It's going to take a little longer for us to prove that the antibodies are truly protective. But that's certainly one level of security is, yes, I have antibodies against the virus, so I feel a little bit more comfortable. And then it's going to take a few months for us to come up with do the studies to show that most people that have this level of antibody in our test tube models, we can prevent infection. Now, we can't really do the in-human model because we don't really want people to get exposed because we don't know if this is going to be effective. So we have to do the best we can in terms of protecting people from their exposures.
Another way this may work is through physician referral. Let's say a large company that has lots of workers and in the warehouse or in the factory or whatever that might be, and can under a physician's referral get a bunch of these tests sent to the warehouse and be able to run their tests on their employees to get a sense of their safety and where they are, and, at least until more is known relative to the workforce and being able to get back into it. So there's a lot of applications that could occur because they're so point of care, rapid, quick tests. They just have to be accurate.
Right.
Yeah. And then another key point is how long do these last? If this continues, the COVID continues, and there's a hypothesis that may come back next, in the next winter season again, will our antibodies last that long, and do we remain protective? Now, the point of care tests are yes or no. They're not going to tell you you have this level of antibody. So there are those types of tests being developed too, and that's certainly something we're doing at LSU, is trying to develop that test to look at the amount of what we call the titer of the antibody response over time, and do you remain of high titers for a long periods of time. Now we certainly know, like for the MMR, that generally with a booster here and there, people do keep pretty good antibody levels for years. And that's how our vaccines obviously protect against those pathogens in the vaccine for long periods of time.
Speaking of that, relative to the antibodies, that's very true. They are around probably a very long time. These trained innate cells are probably not though. They are more transient. We think maybe they're good for a year. Maybe longer. We'll sort of see, but they're definitely not the very large, long-lived type of cells that you get from the adaptive immune response.
Wow. Well, thank you. Thank you again so much. And I'll turn it over to Sam for all the questions.
Yeah, we do have a few questions, and I know that we are running over time, so I understand if anyone has to jump off, but I think that this is very interesting. So if you, Dr. Fidel and Dr. Hagansee, if y'all don't mind answering some more questions, just let us know when you, okay. So we have, how are patients distributed among the 3 experimental groups?
No. It's randomized. So basically when a patient decides to re-enroll in the study, it goes to a computer. The computer tells which of the 3 arms that they're put in. And then the study is set up at University Medical Center for those patients who are admitted to the hospital, but are not severely ill, so they're not in the ICU. And the idea is hopefully to prevent that from happening. And that's gone okay. A couple of weeks ago, there were many more patients in that category than there are now. That's obviously a very good thing. There was a possibility that they're looking at trying to open this up for patients that are not being admitted to the hospital. So they would be also looked at in terms of if they get readmitted and things like that. But logistically, there's some logistic barriers that have to be overcome before that can happen.
Okay. Are medical providers in hospital settings, are they using so you talked about the Povidone-Iodine nasal spray and mouth strategy. Is that?
That was just a suggestion. I have not heard of the nasal spray being used yet. It was a sort of a paper that came out that made the suggestion that 0.5% solution that were up in the nasal passages or in the as a mouth rinse would actually do very well as an antiseptic if somebody felt they would be getting exposed or had been exposed in a very recent past, because it's only going to be very transient.
Okay.
Interestingly, in the Spanish flu epidemic in the early 1900s, the soldiers did do some kind of an antiviral gargle to try to prevent that. From the lithographs I've seen, it looked kind of severe. So hopefully this is a little more easy to handle if it turns out to be efficacious.
Okay. Is there any data regarding children that have not received recommended vaccines? Are they more likely to develop COVID-19?
So there is there's evidence from other countries that used BCG as children that have shown a lower overall mortality rate from diseases in general. So there is evidence out there that's relative to that, but it's mainly from the BCG. And I think that's probably why the BCG is being used more so in these trials. The problem we had in the United States is that the BCG will interfere with the TB test that people take because they have the immunity to it, and the TB test that everybody gets in their arm tests for whether you've had TB or any exposure to it. So there's a false echo there relative to that test. With the MMR side of it, which I didn't mention, but it doesn't leave a scar or any type of lesion, where the BCG leaves a scar similar to what the smallpox vaccine was doing. And so you can do these trials more blinded and randomized because whoever's getting them won't really know whether they've been gotten the vaccine or the placebo.
I think part of that question too was children who aren't getting any childhood vaccines, are they at increased risk of COVID? I don't know. I don't have any data that way. In terms of that, I think it's a very small segment of our population, thank goodness. And but I don't know of anything. The flip side is something we're trying to dig out in some of the patients that had adults who've gotten COVID, is to look back in their vaccine history to see if they had an MMR as an adult or not. That's hard to piece together because our records don't go back that far necessarily. And in this epidemic, sometimes patients are going to the nearest hospital and not the hospital that has all their medical records. But it is one of the criteria that we are going to do with, kind of a chart review in a big sense, where both University Medical Center and that hospital system and Oxford Medical Center and that hospital system and other hospitals across the state are getting together their electronic data to do things just like that. And hopefully we'll have some insights like that in the next, maybe even the next few weeks.
I think from the pandemic standpoint too, when this is all over, we will be able to sort out a little bit more of children that have been afflicted with it and tap into whether they've had the vaccines or not, especially in other countries too. The other countries that are not now doing the childhood vaccines or the BCG anymore. So I think the epidemiology will sort of show itself a bit as time goes on in the pandemic.
Okay. Could cross immunity between SARS, CoV-2, and other coronaviruses have some relevance in mortality reduction?
Well, I think why we're having such high mortalities is just that, is that we are not, this is a relatively new virus, kind of like a new flu epidemic, very similar to that, where we don't have any pre-existing antibodies against something similar, so that we are all relatively unprotected. So I would think the answer would be yes, that if you had some previous exposures, maybe to SARS-1, that you'd be somewhat protected against SARS-2. The SARS-1, there wasn't that many people affected. I think it turned out to be a couple thousand totally. So this SARS, Corona, COVID-19, does spread more quickly than the previous coronaviruses.
The other thing to consider here is on the trained innate cell side of the equation. These particular cells, as I say, are not going to be as long-lived as they would, and it's important to recognize that the live attenuated side of this is very important with the induction of these cells. If you get, let's say, a normal viral infection, you say, well, that's live, should it induce those innate cells? Well, it turns out from our research and animal models and so forth, that any infection that creates damage within your system does not allow those cells to get induced in near the levels or with the efficacy as in the live infections, if you want to call them, that really don't cause any damage or disease.
Okay. Where does hygiene hypothesis fit in with transient trained innate immune cells or immunity?
Wow.
That's yours, Paul.
That's an educated question.
Yeah, so, the hygiene hypothesis meaning that, people aren't out and about as much, and being so clean and cleanliness has inhibited some of the ability to have immunity, general immunity against a lot of things, and that has created a lot of asthmas and allergies and all those types of things. Boy, the jury's out on that. I think that it could have something to do generally with the lack of any immunity towards some of these viruses that are coming up now. I think you look at the fact that SARS, MERS, and now COVID have all happened in the past 20 years. And you're looking at the hygiene hypothesis sort of coming on in the 80s, maybe in the 70s per se, with being more, having more antibiotics and treating things a lot more quickly. So, yeah, I would say there's definitely a possibility, but boy, that's a good question, and some epidemiology would have to be studied on that. But that's an excellent thought.
Okay, and one more question. Any other thoughts besides having an immune booster on why there is such a range of symptoms, even some asymptomatic?
Well, that's a good question. The billion-dollar question. Why most people do fine, and then a few get admitted to the hospital, and even a few of those have a bad outcome. We generally think the viruses are the same. So there was a little variation. RNA viruses vary a little bit, and there is a little mutations, and that's one thing that we'll be studying here too. Does the New Orleans virus different than the virus in China and New York City and stuff like that? But I don't think there's major changes in the virus that changes that's going to explain why some people are getting worse than others. It certainly can be, your ability to fight a virus. Everyone's a little bit different in terms of that. And some people may be able to make an antibody response quicker and they can be protected, or their other arms of the immunity are better. Maybe their innate immunity is somewhat revved up. Could be a little bit of bad luck, and that, on that given day, your immune system decided to take a day off, and that was the wrong day to take a day off. Kind of random chance models. And then clearly what we're seeing is the patients that have comorbidities, and they're the ones that are having the severe outcomes. And the patients that I've seen, in many cases, they seem to get through the lung injury like Paul was talking about, and their lung oxygen requirements are not that bad. But what happens, they have underlying liver disease and their liver gives out. They have underlying heart disease and their heart gives out. Or they have underlying, in the cases that have asthma or COPD and stuff, then they just their lungs don't ever recover. And that, how and why that happens is interesting. One other thing that I've seen happen, and that's coming up, is central nervous system issues, where patients aren't waking up, and they should wake up. They remove the sedation from when they're intubated and they're not responding. I think we're starting to see some autopsy data come out. I know University Medical Center we're looking aggressively at that. It'd be very interesting to see the lung, the heart, the liver, the CNS, the brain damage that's being caused by this virus in these patients who don't succumb to the disease, to give us an idea. Is it the virus that's causing the pathology? Is it our immune response that's causing the pathology, or a combination of both? And again, it's interesting to see that your comorbid state, whatever that is, that seems to be what's the problem when you don't get better. And that might be interesting to see what the pathology of is that person with cirrhosis. What's wrong with their liver, where their heart's fine? And that, from autopsy studies, hopefully we'll be able to determine that.
And some of those comorbidities with diabetes, obesity, heart issues, hypertension, all that seems to play a really significant role in the whole process. But there are just as many people that you would never think would succumb to anything that serious that do. So there's a genetic side to this in some respects, as well as the comorbidities. And I think that in general, I would not have thought when this all started that people would just walk around totally asymptomatic, that they would, the common cold gets everybody in some kind of symptom somehow. And yet, I think we're going to find out that there is quite a number of people that have been exposed and were totally asymptomatic and could have they're now carriers and could have spread it to anybody else without any symptoms themselves. So it's really important to wear those masks right now until we figure out really what's going on.
Yeah, we see this in flu epidemics on like every flu season. Not often, but occasionally you'll have a 35-year-old healthy person that comes in with flu pneumonia and it has a terrible time. And why they should be perfectly healthy and they don't have any comorbidities. Theoretically, their immune system for that particular flu virus did not do the right thing, whatever that might be. Obviously, the vast majority in flu is the older and the younger that get it, and the COVID, it seems to be the older and the comorbidity. There is a genetic component, absolutely, and it would be great to try to understand that better, and hopefully we will.
Well, y'all have your work cut out for you.
Absolutely.
Lots of things to handle coming up. We would love to keep this going all day, but I know it's been almost an hour, and so we are going to stop questions. I want to let everybody know I posted the link in the chat feature. You can find the recording to this webinar on our website. It's lsuhealthfoundation.org/coronavirus. You can also see all the upcoming webinars. Our next one will be Thursday, and that will be with Howard Osofsky, MD, and Joy Osofsky, PhD. And they'll be talking about the psychological and social impact of COVID-19. And that will be Thursday at 2. Crystal? Oh, she's muted.
Muted.
There we go.
Muted.
Oh.
My daughter came in our truck. I don't know, noises. Joys of working from home. Thank you again so much. It was so valuable, and yeah, we could be here for another hour for sure. Definitely tune in on Thursday for the next webinar. Check our website. On our website, there's also a link to where you can post additional questions. So it's ask your coronavirus questions here. So if you have additional questions for Dr. Fidel and Dr. Hagansee, go there, continue to ask questions. We're lucky to have both of you as part of the LSU family and team, and thank you for giving of your time. We'll see you back here on Thursday. Everyone take care, be well, and hope to see everyone soon.
Thank you, everybody.
Thank you, Crystal.
Thank
Thank you,
you.
Sam.
Bye-bye.
Okay.